Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there, there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, and welcome to GasGasGas. Today we are dancing forth with interminable joy, which I'm sure you're all experiencing as you study for this exam, and exploring local anaesthetic systemic toxicity. Now, this is certainly something that I've quite enjoyed looking up and understanding to convey to you, because it really does make us remember that every drug has complications, and that's true from paracetamol to propofol. There is such a thing as too much of a good thing. So, what we're going to talk about: the emergency immediate actions on that really you can apply to any unfolding disaster in theatre or elsewhere in the hospital. Treatment of local anaesthetic systemic toxicity, and then we're going to explore the incidents, the clinical presentation, strategies to mitigate the pathophysiological basis of local anaesthetic systemic toxicity. We're going to chat lipid emulsion therapy, particularly where it came from and how we use it, and then other risk factors for local anaesthetic systemic toxicity, because we are professionals and we should understand how we could just arbitrarily stick to one dose of drug for everyone, but this will ultimately lead us to having a marginally greater chance of becoming unstuck. Someone who might take that one little further cognitive step and reduce that risk and narrow off that bell curve, so you're really only pushing those problems to the very peripheries, because one size does not fit all. Of note, folks, I've managed to convince our dear friend Tom, who's now had his break, to return to the show for more Vivacast fun. However, he returns this time victorious. He's done it. He's had the thumbs up from the Roman Emperor in the Colosseum, and he is now primary FRCA positive. So we're going to do a bit of a reciprocal Viva session, probably like once a month or so, where I put him through his paces and he puts me through mine. We're probably going to do something along the lines of, we each know one of the two questions the other's going to ask, just to keep ourselves on our toes and hopefully generate some interesting discussion from which everyone can learn from, including us. So my first port of call, naturally, is to introduce local anaesthetic systemic toxicity. Systemic is the key point here because we're seeing symptoms across multiple body systems. From now on, I'm going to call it LAST, L-A-S-T, and that's just because it's a mouthful, and I'm going to say it like 100 times otherwise. So we know local anaesthetics are chiefly sodium channel blockers. However, inconveniently for us, sodium channels are not just located on nerves, and subsequently our target, but elsewhere, and herein lies the problem. Because sodium channels are critical to the functioning of your central nervous system, i.e. spinal cord and your brain, as well as your myocardium, that very important perfusing apparatus that keeps the blood going round and round. Importantly, it's chiefly amide local anaesthetic agents that cause local anaesthetic systemic toxicity. And you have to remember, guys, that this is because the ester local anaesthetic agents are cleared by plasma esterases, and that is an extensive system, which means that their capacity to achieve a plasma concentration sufficient to get about and cause bother elsewhere is less. Not completely zero, but less. Therefore, to achieve local anaesthetic systemic toxicity with a ester agent, you'd probably have to be injecting it intravenously with a reasonable quantity in order to achieve problems. Not that that's a goal. We're going to focus on the amide local anaesthetic agents. Remember, that's bupivacaine, ropivacaine, lidocaine, prilocaine, because they're the chief offenders, because they are cleared hepatically. You can imagine that they have a higher risk of accumulating in people. Toxicity is directly related to the plasma concentration at hand. And this is why we're quite interested in how vascular a site is in which we are injecting agent, because that's directly going to relate to uptake of agent from site to systemic circulation, where it is subsequently distributed elsewhere. Last can come about through inadvertent intravascular injection of agent, rapid uptake of agent from space, or uptake of agent from a field block. We're going to cover these in more detail later in the show. I just want you to remember that subcutaneous infiltration of agent is the safest site, then brachial plexus, then the epidural space, then caudal injections, intercostal injections, and then obviously intravenous is the big baddie. I'm sure your brain goes to this thought, because my brain certainly did, but how much is too much intravenously? Well, I can tell you that 2 milligrams per kilo of bupivacaine IV is certainly bad news, and these doses are probably slightly conservative for safety reasons, 2 milligrams per kilo infiltrated somewhere, but less than that is certainly toxic, and that's why you end up with toxicity from a field block, because you're uptaking a certain quantity into plasma and achieving a effect site concentration sufficient to cause side effects, consequences. How much they receive over what period of time is one of the dictating mechanisms of plasma concentration. And this bears out, if you recall, that, for example, bupivacaine in the BNF, it's 150 milligram as a max dose in one go. That's 30 mils. Or 400 milligrams in the course of 24 hours. That would be 80 mils of 0.5. And that reflects the nature of how the drug is being administered. So, in reality, we still want to know how much is too much IV. Some folks in 1971 had a go, and it was Mather, Long, and Thomas, and they had 3 subjects where they dosed them voluntarily with a infusion of bupivacaine, and they gave 1.3 milligrams per kilo, but over actually quite an extended period of time. They gave 0.6 milligrams per kilo for the first 5 minutes, and then 0.75 milligrams per kilo from minutes 9 to 13. The patients received 130, 102, and 104 milligrams of intravenous bupivacaine. None of them had lethal side effects, but they all experienced a variety of those sort of sensory symptoms that we're going to talk about later, particularly symptoms of dizziness and limb numbness, pressure in the ears, feeling a bit vague, dizzy, and one subject complained of an inability to focus their eyes on objects. They didn't have any clinical nystagmus. The trouble here is that none of us are really injecting bupivacaine into someone's interscalene region over 13 minutes. So we would find a peak plasma concentration that would be much higher if we were to inadvertently inject. But we could apply this principle if we were loading an epidural during a laparotomy. We could think about not putting the whole dose in one go. Be a sensible course of action. You never know if it's ended up somewhere it shouldn't. So briefly, dosing bupivacaine, I mentioned the 30 mils, 0.5 in one go in the BNF, but really we should dose by body weight, and that should be done on ideal body weight. 2 milligrams per kilo is the quoted number in the UK. Now, there are suggestions that actually levobupivacaine, you could go a bit higher on that, but few people do, and that's for a very good reason, that we actually don't know how the person in front of us is going to behave with their clearance mechanisms, redistribution, and all the other kinetical stuff that we're going to cover later. Now, interestingly, and we're going a bit off topic here, we're flying off on a limb, that it may be that different mammals behave differently with local anaesthetic agents. And this comes about because some vets decided to try and do interscalene blocks on mallard ducks, and they actually ended up injecting a range of concentrations up to 8 milligrams per kilo, lunatics. Unfortunately, actually, the evidence was mixed, and the ducks did not have a very useful upper wing block. So interestingly, it depends where they were injecting that drug, if they actually had bupivacaine in their ampules, and highlights that the internet is a potent and dangerous rabbit hole where you could end up reading about interscalene blocks in mallard ducks when you're meant to be reading about other things. So that's the introduction done, folks. Let's talk about what you should do when you see an emergency happening in front of your eyes in theatre. And I'll classify this as the core. There is badness happening opening lines. And this sounds great in an OSCE or a Viva, but actually it does also quite help you in real life. So you're going to stop the surgeon if they're operating, unless they're doing something that they absolutely can't stop doing, like stopping bleeding. Declare an emergency to the team. Administer 100% oxygen to the patient. And if you're on volatile, think about how you need to make sure you don't overdose them on anaesthetic agent whilst you're doing so. And call for help / pull the emergency bell. Hopefully you've got an approximate idea of what is going on, and you should declare what you need. Be that an arrest trolley, the malignant hypothermia kit, the LAST kit, local anaesthetic systemic toxicity kit, or the anaphylaxis kit, the hypo kit, and obtain the quick reference handbook from the AAGBI, because otherwise you're going to miss something. Hopefully help arrives, and you need to be getting amongst it and dealing with the problem at hand. My last bit of advice would be delegate reading out that quick reference handbook page that you've decided you're going to go down to someone else. I'd say that if you've got the theatre leader there, be that theatre sister, they're very good at knowing where everything is and following a list of steps clearly, and they can delegate the bits and pieces off to the team that need to occur, like obtaining paraphernalia, difficult airway kit, etc., leaving you to focus on the individual steps that you need to execute, whilst not having to worry about where the MH kit is. So that is your core blurb for any emergency. You stop the surgeon, declare an emergency, 100% oxygen, get help, declare what you need, obtain quick reference handbook, start delegating. So we're going to fast forward in time here, and we're going to tell you that you've had an incident of last and you're doing CPR. Well, the team is. Important things: achieve airway breathing and circulation. Be that 100% oxygen and appropriate ventilation, because you want to avoid accumulation of CO2 and the acidosis that's associated. You need to treat seizures and do so with benzodiazepines. You could also reach for thiopentone. You may want to consider paralysing the patient and intubating them for florid seizure activity, as that metabolic demand will make your resuscitation more challenging, but also the accumulation of lactic acid causing a further acidosis for the metabolic variety is also bad news. We'll talk about why later. Don't reach for propofol because there's no intradipid. Whilst propofol does contain lipid emulsion, it also contains a negative inotrope and systemic vasodilator, which clearly isn't a smart move. So just don't. You need intradipid. What's the dose, you say? Well, you might try and memorise it. You'll probably forget. It is 1.5 mils per kilo over a minute. It'll be in the quick reference handbook, but in a 75 kilo person, it's about 100 mils bolus to get you started. So 250 ml syringes worth, and get it syringed in. It's recommended that we use a bit less epinephrine in this situation, actually, 1 mics per kilo doses. Vasopressin has been associated with worse outcomes in animal models, but we don't reach for vaso in the UK in cardiac arrests anyway. So hopefully we're in a situation where you've intubated the patient, you're ventilating them with 100% oxygen, you've got a defibrillator attached, you've given them a bolus of intralipid, they're paralysed, they've stopped overtly seizing, although they're probably still seizing from a brain perspective, and you need to prepare the next doses of intralipid and an infusion of intralipid at this point, whilst you've got that immediate control. So infuse at 15 mils per kilo per hour. At 5 and 10 minutes, you can give a further bolus of intralipid. At any time after 5 minutes, you can double the infusion rate. There is a maximum cumulative dose of intralipid. I don't know the basis for this. Is that there's going to be diminishing returns? Are they just going to end up with a florid pancreatitis? But if they're going to be dead, maybe think about that at the time. You could also achieve prolonged resuscitation and arrange for them to have extracorporeal oxygenation and perfusion courtesy of ECMO or going on a heart bypass machine. Now, obviously, this is quite hard to deliver unless you've got that in the cupboard somewhere, but have a look at the show notes for 2 events. One, the French managing to put someone on ECMO in the Louvre, and another where the Norwegian hospital system manages to put a trainee surgeon on bypass and rewarm them from 13 degrees. Naturally, the latter is someone who such a slow metabolic rate that you've got time to do it. Former, a bit trickier. So now we've got approximate understanding of how to handle local anaesthetic systemic toxicity last, if it happens in front of you. But how often does it actually happen? Because if it's so rare, we're going to expend cognitive demand thinking about it. So over time, it's gotten less common, and that's probably because of awareness and mitigation strategies. So in 1995, a paper by Brown et al. Showed that there were 79 episodes of seizures in 10,000 interscalene blocks. In a case series pre-1981, there were 100 episodes of local anaesthetic toxicity in 10,000 epidural anaesthetics. More recent data, between March 2014 and November 2016, 47 cases of local anaesthetic toxicity described. 22 of them were treated with lipid emulsion, and 2 of those patients overall died. So historically, the chief offender for toxicity was accidental intravascular injection. However, it also can come about with continuous bupivacaine or amide local anaesthetic infusions, and also in children, often due to weight miscalculations, you end up with last. So great, we know that it's common, but maybe getting a bit less common as we get better at doing these sorts of things safely, and we'll talk about what that involves later. How does it present? So classically, if you're asked to describe this in an exam, it is biphasic, i.e. it follows 2 phases. And actually you can break down each of these phases a little bit further. So there's central nervous system effects, and they tend to come ahead of cardiotoxicity effects. And you experience a patient who has sensory disturbance. So they can feel a bit agitated, they get auditory changes like tinnitus or pressure in the ears, have a metallic taste in their mouth, get circumoral tingling or numbness, and end up with seizure activity. They then become drowsy and comatose and develop a respiratory arrest because the brainstem is pickled in bupivacaine. Generally speaking, you then are meant to get cardiovascular symptoms. That would be something that looks a bit like a hypertensive tachycardic patient who might get a ventricular arrhythmia that then deteriorates into a depressed state where they become bradycardic, they can have conduction blocks and asystole. And that's the classical description. However, patients don't read textbooks, and nor does bupivacaine, in fact. And about 40% of cases in a case series from 1979 to 2009, published in Regional Anaesthesia, suggest that the presentation did not fit that. So it sounds a little bit more like any and all of this can happen in a quite rapid intermingled succession. So someone could just end up with CBS disturbance or just floridly start seizing. Generally speaking, 68% of the time there was a seizure, 50% of the time cardiovascular signs included arrhythmias, and of those arrhythmias, 27% were bradycardia asystole type events. In the days of pre-ultrasound, the onset of toxicity signs from injection took about 50 seconds, and that bears out in a case report of one of the first times lipid emulsion was successfully used in a human. Again, later in the show, exciting stuff. Now, the time to onset of toxicity from initial block is actually stretching out a bit, and that's because we're not injecting inadvertently intravascularly as much, and that's because we are ultrasounding and seeing where the vessels are. It doesn't completely preclude us from doing so, because we might not exactly know where the tip of our needle is if we're not terribly sharp at ultrasound, and just because we've aspirated doesn't mean that we aren't going to inject if actually our aspiration has collapsed the vessel against the bevel of our blunt needle. Interestingly of note, location of toxicity events is stretching out away from theatre complexes into other areas of the hospital that are utilising local anaesthetic agents in these doses. So remember, A&E for fascia iliaca blocks, or patients who are on the wards with erector spinae plain block catheters in for rib fractures, where they're getting topped up. So just to tie that up and summarise things a bit there, whilst there's a classical description, patients haven't read that book. A fifth of toxicity events presented with just isolated cardiovascular disturbance. I think in our collective minds, we probably have a high index of suspicion for strange things happening after injecting local anaesthetic, and therefore we are vigilant for weirdness, and we're not just following that textbook. If something is strange, we should explore it. If something deviates from our expected norm, we should explore it. So now we know. Last happens, it presents oddly. How can we reduce the chances of causing this? So having a pre-calculated dose, knowing what the max dose in the patient is, and thinking about that patient's individual pharmacokinetic behaviour and also their background, frailty, cardiovascular disturbance, hepatic clearance, etc., should be at least partially on your mind. We should incrementally inject with checks for if we're intravascular by aspirating. If we're loading an epidural, we should fractionate that dosing over time. We have the luxury of time in this situation. The goal should be the lowest amount of local to achieve the necessary effect. That effect being sensory blockade for a reasonable duration of time. We should thoroughly communicate with the team that we have administered local anaesthetic as a regional block or field block, etc., whatever we've done, so that the surgeon doesn't also grab local anaesthetic and start injecting. We should use NR fit syringes so that we don't accidentally squirt a load of bupivacaine into someone's cannula, and we should use ultrasound wherever it is available, plus minus nerve stimulators. In some regions and parts of the world, it is more common practice to also utilise epinephrine to make sure that you're not intravascular. And naturally, all our patients should have full monitoring, be that SATs, blood pressure, and an ECG trace, because clearly that's something that we want to spot going awry. Now, we probably just need to take a bit of a breather and a break here, guys, because this is a long episode, and we're about to think about pathophysiology of local anaesthetic systemic toxicity, which is a heavy one, interesting. So maybe just look out the window, catch your breath if you're in the gym, refill the iron if you're ironing your scrubs. Just take a breath. So, you're in the exam, and someone asks you what the pathophysiological basis of local anaesthetic systemic toxicity is. No one's going to shoot you down if you say sodium channels, whilst the target of effect for a nerve block, unfortunately also are present in the CNS and myocardium. These are blocked, leading to the pathophysiological consequences of local anaesthetic systemic toxicity. And everyone will be like, yes, sodium channels are the problem. However, nothing is ever really that simple, because we know that drugs don't just bind to one receptor. They don't just like one thing, because in sufficient concentrations, they might try and jam their way into something else. So we also happen to know that bupivacaine can mess with potassium channels. That impairs repolarization of nerve, but also of myocardium. Gets in amongst the calcium channels in the sarcoplasmic reticulum and messes around with the mitochondria in your myocyte. And actually, it's this last one that is probably the real offender, at least with all the papers I've read to talk about this properly today. So, main mechanism is mitochondrial impairment. And we're going to get a little bit deeper into this in a second, but we just need to think, what about which drug is the bad drug? And bupivacaine seems to be more cardiotoxic than lidocaine. As I mentioned in a previous episode, ropivacaine is actually safer again. Some folks called Rays and Nath injected bupivacaine or lidocaine into the coronary circulation of dogs, and they found that bupivacaine's conduction-altering properties persisted for longer than that of lidocaine, noting that this ratio is disproportionate to the relative potencies of the drug. So bupivacaine really does quite like the cardiac conducting system. Focusing a bit more on mitochondria again, Weinberg et al., and Weinberg is a name that comes up a few times, identified that local anaesthetic agents seem to block the shift of carnitine-like molecules into the mitochondria, inhibiting the electron transport chain, particularly complex 1 of the electron transport chain, at least in rats. And as you all know, and we all know, that the electron transport chain is quite an important part of oxidative phosphorylation, that thing that generates buckets of ATP for a cell. So you can imagine a paucity of ATP in a cardiac myocyte is going to lead to a spot of bother, given we're so entirely dependent on it for those rapid shifts of ions in and out of these cells and the contraction of said myocytes for pumping that blood round and round. So it already sounds like quite bad news to have local anaesthetic systemic toxicity. Now we need to imagine our patient, they're in a VF arrest, no blood is going round and round. And we know what happens in cardiac arrest. CO2 goes up, even though we're ventilating someone, because we're shifting less blood past their lungs. Cellular metabolism shifts to an anaerobic state. They're going to start producing lactate, although we have to note that some of this does just get stuck in cells and tissues because, again, there's not enough blood flow going round and round. And patients become acidotic. Now, this is an inconvenient exacerbator for us because, as we've mentioned before, local anaesthetic agents have a tendency to bind to alpha-1 acid-glycoprotein in the plasma. However, acidosis displaces that from these plasma proteins. So your patient's already sick, they're in VF, their biochemical state is deteriorating and actually liberating further agent that can cause further problems. So as the wheels are all falling off, it's starting to tumble down the hill in an ever-accelerating process of badness. That's why we need to get on top of things promptly and get that intralipid in promptly. So now we know that the mechanisms that mediate local anaesthetic systemic toxicity include sodium channel blockade, also potassium channel blockade, calcium channel inhibition in sarcoplasmic reticula, and impaired mitochondrial function, leading to diminished ATP in any cell affected. So what is this lipid emulsion stuff, and where did it come about from? Well, lipid emulsion is actually just the stuff that patients get given as part of TPN. It is derived from soybean oil, and it contains egg phospholipids and an anhydrous glycerol compound. So Weinberg, we mentioned him earlier, he works at the University of Illinois, he has a laboratory named after him, stumbled across intralipid, by the sounds of it, when trying to explore the issues with carnitine deficiency in rats. And he was administering lipid emulsion and accidentally found that it made it about 50% trickier to get the rats cardiotoxic to local anaesthetic agent. He then went on to publish a paper where he was using lipid emulsion infusions to rescue dogs from bupivacaine-induced cardiotoxicity. That was published in 2003. And the journey to intralipid being in every theatre complex in most modern hospitals in the world started there. The first case report of success in a human that I've come across was from Rosenblatt in 2006. and they described the successful resuscitation of a patient with toxicity following an interscalene block. And the report tells quite a story, so there's a link in the show notes to that. It is quite a read. Intralipid has been in guidance for local anaesthetic toxicity in the UK since 2007. Now, how does it work, intralipid? So the proposed mechanism is the formation of a lipid sink with a rogue free fraction of local anaesthetic agent in the plasma. If you draw that free fraction into the lipid molecules that you've infused, you reduce the free fraction in plasma. This means that local anaesthetic agent in tissues with a high concentration of agent are going to be tempted to partition away from that tissue into the plasma. As that is pumped around the body by CPR, it'll end up in situations where it is an environment in the body where there's less local anaesthetic. It will then partition out of that lipid into other tissues. So the key word to use to describe this is shuttling. So local anaesthetic is liberated from tissues of high concentration and subsequently distributed to areas of low concentration. So it's working to homogenize the concentration of local anaesthetic throughout that multi-compartmental system that is a human. This would happen of its own accord over time, but we might end up in a very bad situation if we just tried to wait it out. Now, there are some other suggestions that it also helps providing a direct source of energy by delivering fatty acid to mitochondria, and that triglyceride may also alter myocardial calcium concentrations, improving contractility. Now, it's found that contractility improvement doesn't come about until you've actually shifted enough local anaesthetic away from myocardium. Intralipid does not work every time, all the time, but it's certainly more effective than nothing. Now, you could, as I mentioned earlier, get a patient onto ECMO or bypass if that's lurking at the end of your theatre complex corridor. That's a challenging thing to deliver in most places. So now we're looking at our patient list Monday morning, thinking block. What are the risk factors for these patients for local anaesthetic systemic toxicity that I should be aware of? So patients with pre-existing heart disease are more likely to have complications from a cardiovascular perspective with toxicity because they're already a bit frailer. General frailty, patients with diminished muscle mass, patients who are at the extremes of the age spectrum, so very young and very old, diabetic patients probably because of the wide-ranging effects of diabetes to multiple physiological systems. Patients with poor hepatic perfusion. Now, even when the liver is really on its last legs, it still makes quite a lot of proteins. So liver dysfunction isn't an abject disaster. And then a risk factor for last, acidosis. You're probably thinking, well, why am I anaesthetizing a patient with acidosis? If it's someone with a gangrenous diabetic foot dangling half off, and they're actually an acute renal failure patient courtesy of their diabetes, and that they have a grumbling acidosis, you need to think carefully about that sciatic nerve block and the dose you might choose to administer. It's probably worth spinal because then you're using less local. And patients with reduced plasma proteins, particularly alpha-1 acid glycoprotein. Now, interestingly, that is an acute phase reactant protein, so it goes up in post-op inflamed patients, polysicky infected patients. So maybe they are less likely to have local anaesthetic systemic toxicity if they've got more of it floating around. And one of the most influential risk factors is choosing not to use ultrasound, and that increases your risk by 4 times. So get that ultrasound probe out, folks. And then there's a few patient groups just to highlight. So pregnant patients. Now they have quite a robust and driven cardiac output with blood hurtling around them and like 30 to 40 to then 50% more than baseline. They also, unfortunately, have less alpha-1 acid glycoprotein floating around. So now we've got a patient with high output, means that they're going to perfuse wherever you inject local anaesthetic more and mop more local anaesthetic up from that region and partition less of it into plasma proteins where it can cause less mischief. Additionally, for the cohort of this group that gets an epidural, they have engorged venous systems within their epidural space. So there's more room for this local anaesthetic agent to stretch out to places unknown. However, it does just seem that we still use 20 mils of 0.5 up to for an epidural top-up, even though they've had an infusion of 0.1 for a period of time. But just remember that they are technically at a slightly higher risk of toxicity than someone who is not them. There are a number of pharmacokinetic peculiarities in our paediatric population that lead to an increased risk of toxicity. So the very young have immature hepatic metabolism. They have less alpha-1 acid glycoprotein floating around, and their capacity to clear anaesthetics is not really going to hit adult levels until about 6 to 9 months of age. It's probably a bit harder to identify signs of CNS toxicity in this patient cohort if they can't complain to you that they've got ringing in their ears or their lips feel tingly. And then the juxtaposition to the very young is the very old. So elderly patients could be described as having a lower clearance rate, so therefore could potentially accumulate more local anaesthetic with infusions. And they have a reduction in muscle mass and total body water. Remember, babies are very watery, old folk are quite fatty. This may result in a larger volume of distribution, i.e. a bigger swimming pool with which you can fill local anaesthetic prior to them hitting a toxic point. So just to tie up liver disease and renal dysfunction more closely, liver disease patient can have a single shot block with a normal dose. Some of the papers I've read would suggest that continuous infusions and repeat blocks, you should think about reducing the dose you're giving by up to 10 to 50% because of the accumulation risk secondary to their impaired clearance of agent over time. And those with renal dysfunction, approximately a 10 to 20% reduction relative to their degree of renal dysfunction. They have reduced clearance of this agent as well. Now, we're really getting into the long grass in this episode, and I just want to hit one last point that might come up in the exam or in a paper, is this concept of CNS to CVS ratio. And what this is elaborating on is at what dose does this drug cause a seizure versus at what dose does it cause cardiac compromise. As you might expect, we're actually quite happy for a patient to have a seizure compared to them having an asystolic cardiac arrest. So if an agent has a tendency to produce seizures, we are probably going to end up ahead of the curve in treating them and preventing said toxicity. And bupivacaine is a winner here when compared to lidocaine. I think ropivacaine is probably safer again. Now, I'm not going to say that anything in the exam is designed to catch you out, but don't forget that if you inject local anaesthetic directly into a nerve, it is neurotoxic, and there's definitely evidence to suggest that it's also toxic to cartilage if injected into a joint space. Remember, that's a differentiation from a local toxic effect to a systemic toxic effect. So in summary, have a high index of suspicion for weird things going on after you've administered local anaesthetic. It's always worth explaining to patients that there is a potential for the toxic effects of this regional block to make them quite ill, and ask them to let you know if they have any altered sensations or unusual feelings. I'd be tempted not to tell me if you get tinnitus or your lips tingle, because they then might ignore or disregard something else like pressure in the ears or not being able to see quite straight. 100 mils of intralipid for a 75 kilo patient will get you going in an arrest situation. Always use the quick reference handbook. Delegate it if you can. Be wary of patients who are on continuous infusions of local anaesthetic agent, especially if it's a high concentration. Communicate clearly with the team that the patient has had a block. Use the minimum amount required to achieve the goals of that block. Remember that last pathophysiology is sodium blockade plus a bunch of other things, and that intralipid works by shuttling agent from high concentration regions or high concentration compartments in your human to low concentration compartments in the human, speeding up the redistribution process and hopefully getting you under a toxic threshold with which you can achieve a return of spontaneous circulation. So thanks for listening, guys. As you might have gathered by all the tangents we've just disappeared off into, I quite enjoyed this episode. Who doesn't really enjoy reading about interesting physiology and how the science came about? I think we all need to say thanks to Dr. Weinberg if we ever stumbled across him. For those with curiosity on the topic that extends beyond this podcast, which I'm sure is every one of you, check out lipidrescue.org. This is where case reports of using lipid rescue for other poisonings are documented, because it is a sort of drug of last resort in a number of other lipophilic agent poisonings. Interesting stuff. Have a nice week. Cheerio, folks. Bye-bye. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.